Hi guys, as we wrap up week 5, we were looking at cardiac problems. So we really had been working on dysrhythmias, then leading into those cardiac problems, and then to me, shock tends to follow that. So it's a sequential thing. It makes sense how we're going into shock next. So some of the things that I'm hearing from you, those of you that have been in your clinicals in complex care, are the amount of drugs that your patients are on and the amount of autonomy that you're seeing your nurses uh, be able to identify with or be able to demonstrate. And that's really an exciting thing to me with complex care. But if you think about it, you really couldn't provide care well in a complex care situation such as the ICU without being autonomous, because you have to make so many of those decisions pretty quickly based on what you're seeing with that patient. So based on those parameters that you're seeing, blood pressure, heart rate, etc., all those things. So pay attention to how they're making those decisions based on their assessment. So it always comes back to what's that assessment of that patient. Even from day one, when we started hammering you guys for assessment, it continues. So especially with those complex patients, no matter what the issue, if it's respiratory, cardiac shock, whatever, we have to go back to that assessment. That assessment's going to be what fuels our nursing care with that patient. So wrapping up that cardiac, moving into shock, and then you're continuing to work on your transplant module. Several of you have already finished your transplant modules. Don't forget, when you finish that, you have to shoot me an email. I send it over to my Mid-America Transplant, and they provide us with that certificate, and we upload that in the course. The interesting thing to me is when you're seeing that transplant thing, think about some of those patients that you're seeing in the intensive care units and how very critical those patients are. It's almost, I call them brittle, because it's almost like the least little thing can cause us to lose them. So paying attention to how that Mid-America Transplant falls within the realm of complex care is interesting to me. So as we're looking at shock this week, I wanted to go through this one real quick because I don't have it open for you. I just wanted to run through it. So when we're looking at shock, um, this one in particular is a 52-year-old male with hypovolemic shock. So that right there tells you what we're looking at, a low volume. This one is because he had a lot of bleeding from an injury. So I'm going down here to this one. How does the body in shock cause the pulse pressure to narrow or decrease? So that pulse pressure, the difference between my systolic and diastolic. So as my systolic is dropping, because I'm hypovolemic, it's going to decrease or narrow that pulse pressure. And look at this second or third question here. What is my priority patient problem? So you're seeing this if you're in your complex care, if you finish that. How do I determine what I do first? Prioritization is a big deal with complex care patients, as it is with all of our patients. But because of the nature of how quickly they can turn, it's a very important skill to be able to master with our complex care patients. So what is that priority patient problem with an individual who has hypovolemic shock? So when we're looking at that, we're looking at that decreased blood volume, so that decreased circulation, which can lead to that hypoxia, impaired tissue perfusion, confusion, anxiety. That hypoxia can go right back into what we were talking about last week with our cardiac problems if we don't have that perfusion ability. And then notice what it talks about organ function, etc. And then last thing here, as Mr. Williams progresses, what members of the interprofessional team should be consulted to address care coordination and transition management? So hopefully you're seeing some of this. Social services case management comes in very frequently. In most of our ICUs, we have dedicated case managers that are just in that unit to help facilitate the next step for that patient, whether it be Mid-America Transplant or on the other end of the spectrum where we're able to discharge that patient to a step-down unit or a medical surgical floor. And then chaplain services, I always feel like although we can provide a lot of emotional support, utilize the other people that you have available to you. Chaplain services are great when you have those individuals and their family members that just need to talk and to share. By all means, utilize chaplain services to be able to take some of that load off of you, and then that social services comes in conjunction with case management, working with family. What do we need to do to help facilitate care for that family? So let's work on shock with this week, and then again projecting out for next week. We've got our HESIs for next week in week 7. So let me know what questions you have, and keep journaling on your reflections for your clinical days, and let me know what you need. Thanks, guys.